Hello, I'm Dr. Chris Hussey, orthopedic surgeon. Welcome to Fairwinds Medical Healthcare Unscripted podcast. Today we are honored and pleased to welcome Dr. Hunter Greene. He is a total joint and sports medicine orthopedic surgeon from Sacramento. Welcome, Dr. Greene. It's a pleasure to have you here today.
Oh, thank you so much for having me. It's a pleasure getting to sit down and chat with you. So looking forward to it.
Me too. Me too. There's a lot of fertile ground here. You and I spoke the other day. Your training is extensive, obviously, and you do some things that most orthopods don't do. One, I know that you're sports medicine oriented, and I want to talk a little bit about the teams that you cover and what you do. Let's talk a little bit about your arthroscopy techniques. Not a lot of orthopedic surgeons do hip scopes. Can you tell us a little bit about that?
Absolutely, yeah. So I entered fellowship in 2004 after completing residency and probably saw less than 5 attempts at hip arthroscopy during that time. It was kind of early inroads into it at that time. I think Dr. Glick in San Francisco, Tom Bird was doing them, and McCarthy in Boston. So a few guys around the country that were actually kind of doing them on a regular basis. And then as I entered fellowship, Mark Safran, who I did my fellowship with the UCSF, was just starting to do hip arthroscopy and asked me if I wanted to learn along with him. And I said, absolutely. So that was kind of the beginning of it. And once again, this was kind of early on in the process of hip arthroscopy. And then since then, we've seen just kind of a exponential explosion of hip arthroscopy. It's commonly trained in residency programs now. It's much more in the public view. Radiologists, primary care doctors, people are much more familiar with the process. When I started out, we didn't order MRIs for hip pain. I remember in residency seeing patients in our joint clinic, the young 40-year-old guys with cam lesions, but we didn't call them cam lesions back then. We just told them to do some physical therapy, and we would never even think of ordering an MRI on those patients, but now it's commonplace.
Well, it is. I mean, it's becoming more so. Majority of orthopedic surgeons don't have that training, so they don't do that. I want to back up a little bit. Tell me a little bit about where you're from in Sacramento and what your practice, kind of, if you can expand on that a little bit.
Sure. Thank you. Yeah. So kind of was born and raised in California, Central Coast area, kind of between Santa Barbara and San Luis Obispo. Did my undergraduate work at UC Irvine, and then traveled to the East Coast to Boston for med school at Tufts. Completed my residency at Yale, and then came back to the West Coast for my sports medicine fellowship at UCSF. And then after that, we moved up here to Sacramento.
Very good. And how long have you been in practice?
Since 2005, so just a little over 20 years.
Awesome. That's terrific. So again, you fill a niche that most orthopedic surgeons don't do. Can you tell us a little bit about your indications for hip arthroscopy?
Absolutely. So once again, kind of just beginning at the process, figuring out who's a candidate, who's not. Like I said early on, there wasn't a lot of literature to kind of base things on. This was a lot of kind of trial and error, learning as you examine patients, trying to figure out how to indicate for hip arthroscopy, getting some imaging, MRI arthrograms in the past that we would get. So first and foremost, kind of the history of how long they've had hip pain, what bothers them, what activities would do that. We see a lot in runners and rotational sports, golf, tennis. Not so much like in a soccer sort of change of direction sport, but much more of a kind of a power rotation sport. We see those things. And then just people in general in life as they go through activities, most of our labral tears kind of come over time, like meniscus tears, but occasionally they're traumatically associated labral tears, but they're far less common. And then just getting good imaging to assess for any form of impingement, seeing those are the kind of the factors that kind of put you at risk for having a labral tear. And then, going through the process of conservative care, physical therapy, pelvic core strengthening, pelvic positioning, looking at, I use diagnostic injections a lot for determining if patients have ongoing low back pain along with their hip pain. It helps kind of, if you numb the joint, we kind of tell them whatever gets better there will likely improve with surgery. Anything left over is probably coming from somewhere else. So those patients we kind of work through and then go through the surgical process of, seeing who's the best candidate.
That is always the conundrum between whether it's coming from the back or the hip. Can you tell us a little bit about your actual technique for hip scopes? Because again, not a lot of orthopedic surgeons scope hips.
Yeah, so it's once again a little bit of an evolution, starting way back because it's a big setup. You have fluoroscopy in the room, you have your arthroscopy towers, you have just the devices in the table alone. We began with sort of a fracture table style approach, which is not small. They have large footprint. So going from trying to coordinate everything in the OR, figuring out where you want to position things, where the floor should be, where the arthroscopy tower should be, your Mayo stand, everything else. So back in the past, doctors would do a sort of a lateral approach. Most did supine. I learned supine, so I stayed that way. I've evolved from different traction tables to now I'm actually using a postless table. So there's no perineal post, which is great for patients and any sort of risk for nerve injury with the procedures we're doing. So I evolved all the way to that. So I do a supine on a postless table, usually 2 incisions, sometimes 3, depending on what we're doing.
What's a typical patient population, and what's the recovery process?
Yeah, so I've kind of spanned the gamut from probably I think the youngest person I've scoped is around 13, but most of are in the late adolescence all the way up to late 50s, 60s. Really interesting how this has kind of evolved over time. I think when you get into your 60s, it's you can get a degenerative labral tear that behaves very much just like a degenerative meniscus. If you have a decent looking X-ray of your knee, but mechanical symptoms from your meniscus, that surgery usually has a great outcome. They do well. They're back on their feet. Same thing if you have decent X-rays for a 6-year-old person of the hip, but they have true mechanical symptoms from a labral tear. That's a labral debridement, get in, get out, about 30, 45-minute surgery, just like a knee scope, and they have really good outcomes. Then you have your, mid to late 20s, male who has a cam impingement and a labral tear, hopefully not any condyle delamination with it, but go in, fix the labrum, do a labral repair, do your femoroplasty, resect the lesion on the femur. And for those guys getting back to sports, we usually talk to them about kind of a 4 to 6 month return to sport. During that time, they're doing their physical therapy. I'm evolved my rehabilitation and kind of post-surgery recovery immensely. At this point, I'm doing the first 2 weeks at what we describe as sort of a 50% partial weight bearing. Then from 2 to 4 weeks, getting them back to full weight bearing. I want early muscle engagement, get the glutes engaged, just like with our ACL patients now, wanting to get the quads involved. Glutes are the key for getting the hips going. So we do a really early engagement program for the hips and glutes, get the core involved. So I like my patients to be up and active quick. I tell them, early on, be fidgety, up a little bit, down a little bit. And in the end, hip patients, they feel best when they're moving. They don't like to sit for too long or stand for too long.
I agree with that. So I know you do a lot of sports medicine. Tell me a little bit about that. I know that's a big part of your training. It's also a big part of your practice. What all are you involved with on that?
Currently, I'm fortunate enough to be serving as one of the athletics team physicians here while they have their stint up in Sacramento. I did that last season. Again, this season, it's been great to be involved with that. The MLB is an excellent organization. They do a great job. The players, essentially all the A's are my boys, so it's just like hanging out with my kids on a daily basis. They're great guys and just amazing specimens of athletes. They're truly like the upper 1% of the people out there, what they are able to do and perform at this extremely high level. There's been some really fascinating things that I've learned at this high level athletes is recovery times are very different than what you'd anticipate sometimes for a normal patient you'd see in your practice. A typical hand fracture in someone that you'd see in your clinic for a metacarpal fracture, by 4 weeks they're back to work doing things like that. Actually, their time is extended longer than that because of, once again, the forces, the power that they generate. For one of these guys to hold a bat and hit a 100-mile-an-hour fastball, it may take them 6 or 8 weeks to get back doing something like that. So it's a little flipped on some of the things you would think as far as the recovery.
That's fascinating. It really is. You have a practice that most of us would envy, and the things that you were able to see and do and get to know these elite, as you said, 1% players, and to find out that they're actually, good people and they want to engage and they want to share and befriend you. Do you work basically in the sports medicine world? Are you solo or are you with a group with that? Or
so for my practice, I have one additional partner. He does total joints, so it's a good sort of yin and yang for us in the sense that prior to kind of outpatient total joints, we had kind of mirrored practices. I would do about 80 90% of my practice outpatient. He did the same for inpatient, but now with the advent of doing outpatient total joints, he's in the ambulatory surgery center as much as I am. So, but yeah, it's a great practice. So we share patients back and forth. One of the kind of touching back on the hip arthroscopy side is there's some interesting work with total joint patients. They get psoas impingement at times after total hips based on a variety of strange regions. That's one of the other kind of small niche sides of hip arthroscopy that I do occasionally in those patients as well.
So where you're practicing is essentially the cutting edge, so to speak, of orthopedics. Are you finding that the majority of joints now are outpatient total joints?
By far, yeah. The volume of outpatient total joints that are done now, I mean, I think I do shoulder arthroplasty. I don't do a lot of, I don't do any hip arthroplasty, and very rarely any sort of partial or total knee arthroplasty. But all my shoulders are essentially outpatient. Even if they're done at a hospital setting, they go home the same day. And that's a big credit to our anesthesia colleagues that do these great blocks that allow them to kind of wake up and pain free and get home comfortable.
That's terrific, and what a benefit to your patients that you're able to do that. So I want to shift a little bit now to ACL reconstructions, because I know that that is a big part of your practice. Can you tell us a little bit about your technique on that?
Oh, for sure. So once again, and we spoke when we spoke the other day. Kind of you've seen the entire evolution of ACLs from an open procedure to an outpatient arthroscopic procedure. When I first started here in Sacramento and doing arthroscopic ACLs, it was still they would ask me, is a patient staying overnight? And I'm like, no. It was kind of a shock to me to think that they would stay. So now my current technique is to do an all inside technique with a retro reamer for the femoral and the tibial tunnels, trying to really recreate the most anatomic footprint we can for the femoral and tibial aspects, trying to, we know if that's in the right spot, we're going to get better rotational stability and improved outcomes. For my graft choice, mainly hamstring autograft for my younger patients. I've also started to do some quads for revision patients, looking at LET as well for revision patients or patients that have a little more instability than we'd anticipate in a primary setting. And then, I use allografts for older patients or a multi-ligamentous knee. So that's never been a huge fan of bone patellar tendon bone. I just think it works great for larger athletes, but for a 5'4", 115-pound soccer girl that I don't think they need a 10-millimeter graft. And unfortunately, with the bone plugs, you kind of have to kind of keep it in that realm to lower the risk of fracturing your bone plugs in those settings.
So I'm going to touch on something here. What do you use for your fixation on both femoral and tibial side? I've been around long enough to see the evolution from when I was a resident. It was basically a total knee incision. I mean, it was just, and now, like you said, it's all inside, and the rehab is so much better, and the results are so much better. Fixation-wise, I think that there's still a lot of variation on how different surgeons do fixation. I'd be curious not only to what you use, but what have you seen evolve in this process?
Absolutely. Currently, I use kind of a cortical fixation or suspensory fixation with a loop structure, so the graft is looped over what would be traditionally the kind of endo button sort of style, but this is the pro cinch is what I use. I think, nowadays too, especially with these kind of Chinese finger trap sort of tightening devices, you can really get a very solid graft that doesn't stretch, that doesn't move. They've looked at all the different studies with interference screws and bone fixation versus soft tissue fixation, and they all have some mobility early on anyway, and that's just, I think, the nature of it, whether you think you get great fixation, but there's still a little bit of creep in there that we can't really get rid of completely, because I think naturally the body wants to move a little bit. And I think I mentioned on the phone the other day, I had the honor of working with Dr. Dale Cannon in San Francisco, and he was a very traditional guy, would use a suspensory fixation on the femoral side, then kind of very much the kind of screw-in washer on the tibial side for his fixation, and he did a hamstring graft at that point, kind of quadrupled graft. So I've seen all the different ones, and some people still use interference screws or with a backup fixation. I don't think there's really currently, with all the options that we have for fixation on both femoral and tibial sides, there's really a wrong choice. They're all excellent.
No, I would agree with that as well. That's really interesting. Can you expand a little bit on your rehab protocol for this? Talking again about ACLs. Because the fixation is so much better now, and we've seen the rehab evolve significantly. And again, you're on the cutting edge. What do you all do now?
Yeah, so we're fortunate. We have some pretty high level physical therapy in our area here, so we're fortunate with that. One of the things I think that's kind of really been a big leap forward is the use of BFR, or blood flow restriction therapy, for the ACL rehab. So I kind of describe it to my patients as, you can load the muscles without stressing the joint. By using the BFR cuff, you can, trick your thigh to think it's squatting 400 pounds, but you're just moving your leg up and down. So they get a huge kind of stress to the muscle without stressing your implant, stressing your graft, and anything in that sense. And I also like, for some of my older patients that have some early arthritis, for their training regimen, recommend using some BFR as well for just their normal rehab or exercise program to lower the stress on the joints, but still get some muscle strength out of it.
Very good, very good. So obviously the rehab has advanced significantly, and the return to sports and everyday life is much, much faster now. What have you found to be the most important advance in ACL reconstruction technique?
Yeah, I really think the ability to retroream and target, because once again, the early era was the transtibial, and we know that with the transtibial approach, and unless you're using sort of a curved reamer, you're not really recreating the true anatomic location of the ACL on the femoral side. So the ability to kind of target that without drilling from the outside. There are some nice nowadays these flexible reamers that allow you to kind of come through either medial portal or even sometimes through the tibial side and recreate that footprint. But I think that ability is to be able to have the retro reamer, because the tibial side's always been fairly straightforward as long as you get it in the right spots. With the femoral side, we all saw those very anterior grafts, very vertical grafts that provided excellent anterior posterior stability sometimes, but not a lot of rotational stability. So I think the advent of being able to get more anatomic on the femoral side has been a real leap forward as far as our athletes getting back to the rotational sports.
So the location of the femoral side and that tunnel is critical. Can you give us any tips and techniques that you use to get the anatomy where you want it to be, where it has to be?
Yeah, I mean, if like I said, we always kind of rely a little bit on if there's a little bit of the footprint left there when we're preparing the notch. If there's a little something there, that's always kind of a caveat.
So you still do a notchplasty as well?
No. Just when I'm preparing the notch, as far as like ablating down the soft tissues. Yeah, no, I don't. I haven't done. I kind of have never really done a notchplasty unless there's something, because if we've all scoped knees that have had notchplasties and they're never there when you come back. And kind of it's a fruitless operation. But the position that I really like and I utilize sometimes is in the figure four position. You can actually see, if you look at a lot of native ACLs in the figure four position, you really get a much better sense of where it inserts onto the femur on the posterior condyle there. So I really like to use that. Sometimes I'll actually put the leg in the figure four position and use my ablator to kind of mark out my spot that I want to come back to when I do the femoral sided tunnel. So I really try to use that as a guide, and just knowing that's when I look at all my native ACLs, try to liken that to when I'm doing my reconstructions.
I think that's interesting. Again, going back to the evolution of this figure four positioning, that has come along recently, but most orthopedic surgeons don't use it because they weren't trained on that, and they're just not really comfortable with it. How did that come about for you? Was it just part of your training, or just something that you and your partners started to develop? Obviously, if you look at the data, the outcomes are better. I mean, they're just better.
Yeah, I think it was just one of those things. I wish there's not a great story behind it, other than like just when you're doing just my normal knee scopes, you kind of, as you finish, you look up and there's the the ACL footprint. And also, if you ever look back at your reconstructions you've done that you have to come back for some reason for, and the graft is intact, you can always kind of see how I did with my placement, in relation to a native ACL. So I always love that position to kind of check my work in a sense and look at that. But yeah, it's no fantastic story about it, but other than just kind of just day in and day out arthroscopy, looking at that spot and noticing that this is the best way to kind of see where it originally originates from.
I think that's a great tip because I think that not everybody does that. And I agree, if you take that a look at that position just on a regular knee scope for a meniscus or something, and just get used to looking at that and seeing what it's supposed to look like, it makes a big difference when you actually have to go there and you know, drill a tunnel, and then you're more comfortable with where your anatomic placement is. So I think that's critically important.
Healthcare Unscripted is powered by Fairwinds Medical, the commercialization team behind some of the most innovative technologies entering operating rooms today. With national reach and clinical expertise, Fairwinds moves new solutions from promising to practice. Visit fairwindsmedical.com to learn more.
So I want to shift gears here a little bit to shoulder, because I know that that's also a huge part of your practice. I want to take us from not only just shoulder scopes, but also shoulder arthroplasty, because I know that that's a big part of your practice as well. So let's just kind of take it from the beginning of you're going to scope a shoulder for cuff or labral whatever, and then how you that ultimately kind of evolve into an arthroplasty.
Yeah, so let's start kind of the younger age. That's our more instability patients. We've really kind of learned a lot, I think, over the course of time, and some excellent literature as far as, the ultimate goal for any unstable shoulder in the end is to be stable, whether it's through surgical stabilization or just, time and rehabilitation. So I have my first time dislocators have a very long discussion with them talking about, what the ultimate goal is. You see the 21-year-old kid who dislocates snowboarding, and listen, I don't want to see you when you're 38 and you've dislocated 38 times, because that shoulder is not a fun shoulder to work on, and the options are far less. So it's the one thing that I'm fairly aggressive about as far as surgically, is having a very kind of frank discussion with the unstable patients, that you get the first one's your mulligan, and then after that, if you have another instability episode, you should really strongly consider surgical stabilization, especially with it in that first year. And I think the advent of the remplissage procedure has been I think it's changed a lot as far as our reduced dislocation rates. So I really like that procedure, and there's some fairly straightforward techniques for it, but I think something that I've really kind of involved in my practice now, where I wasn't doing one 15 years ago.
So I want to talk a little bit about that. Can you elaborate a little bit on what your different stabilization techniques are? Specifically, let's just start with something as simple as a rotator cuff repair.
Sure.
Let's say you've got a multiple dislocator. How do you stabilize that joint?
So for that patient, let's say the kid's been out 5 times, and now we kind of got a hold of him and convinced them that it's the right thing to move forward. Your imaging is going to kind of guide you a little bit, but I think it's your examination in the OR asleep, and also your arthroscopic examination to kind of seeing, hopefully ahead of time, we know if there's any glenoid bone loss that we'd be concerned about. I think the Hill-Sachs lesion, we can tell by imaging, but it's really an arthroscopic evaluation, both from the posterior and anterior portals, to kind of get a good sense of the depth, the size of that lesion, and then whether it's engaging as you kind of move them forward. If you can simply push the head out and it locks on that lesion, that's a big concern. So I always kind of go with the remplissage first if I'm going to do that, place my anchors, and then not tighten anything down, but then go back and then do all my Bankart work. And sometimes a couple of kids lately have had Bankarts all the way up into slap lesions, so you're dealing with or posterior labral tears as well. So, but dealing with the Bankart lesion after the remplissage anchors are in place, stabilize nicely anteriorly, get the capsular tissues back secured, and then finish off with the remplissage. I always like to look from the anterior portal, kind of the over-the-top view, making sure the humeral head is nicely centered over the glenoid and have good resistance to anterior and posterior forces at that point.
So I really like that. I appreciate you walking us through that, because I think it's an important process for us to think about as surgeons, is going through that process. Do you find when you've done rotator cuff repair on a multiple dislocator, is that rehab different?
So those patients are extremely challenging, because you have the two things you're battling there. You have somebody who you want some immobilization for some stability for the capsular tissues, but you don't want to get stiffness because you want the cuff moving. So it's an extremely challenging sort of patient to try to run that fine line, and that's where you rely heavily on your therapist to be really good with, the discussions with the patients, the do's and don'ts, the sling time, everything else like that, to make sure that you're trying to win on both sides of the equation there, with getting enough immobilization to allow your capsular tissues and your labral tissues to heal, but not too much to where your cuff gets really stiff.
Very good. So if you're trending towards an arthroplasty on a patient, do you typically scope them first during the same procedure and then go on to the arthroplasty, or not?
No, usually at that point, a lot of these patients are fairly end stage as far as their arthritis, and whether it's cuff tear arthropathy or just cuffs intact, but fairly advanced glenohumeral arthritis. Those patients, I really love arthroplasty. I've seen the extreme benefits. Just like they're very happy patients. They're happy to have their function back. They're pain free most of the time. It's kind of like total hip patients are very happy patients. I think shoulder arthroplasty patients fall into that. It's a pretty similar category. Knee arthroplasty patients they're tough. It's a tough operation. But shoulder arthroplasties, I tell my patients fairly consistently, we're going to improve your pain and improve your function. And most of the time by 2 months they're pretty happy.
Do you typically only use reverse?
Yeah. So beyond 65. I highly recommend it because I always tell my patients, if your cuff works, the reverse works. If your cuff stops working, the reverse still works. So it saves you from coming back for another operation if you do an anatomic total shoulder, and then from 5-10 years down the road their cuff fails, you're gonna have to come and convert them. So in that age range, I think the reverses have great durability. Return to function is quick. So I'm very pleased with that operation. I think it works great.
I agree. My practice has evolved to where I only do a reverse now, just because the results were so good and the range of motion is so good. And as you said, the rehab is so much faster. And I do think that they're happier. My issue with a traditional total shoulder replacement was their range of motion was just so limited afterwards, no matter how well you repaired the cuff and everything.
I was with my anatomic shoulders. Always just on the edge, waiting for that, 2-month X-ray with the axillary view is the head subluxed anteriorly, or it's you're just like, oh God, here we go. And that's like so the reverses, the fixation's fantastic. They're happy. I put my patients in a sling for 2 weeks and then tell them just start using it. I let them go pretty quick, and at 2 months, their 2-month visit when I see them back there, it's like. I just tell them, they ask about therapy. I said, at this point, your therapy is just use the shoulder for what you need it to do. The more you make it do what you need it to do, the better it'll get at that. So that's the kind of the mantra that I tell them. And I really don't think they need too much therapy beyond that, other than just life.
I think that's spot on. I have enough patients in my practice to where before I started doing reverse, they have a traditional total joint on one side and they've got a reverse on the other. And their basic question is, why didn't you do that the first time?
Yeah.
We didn't have it then.
I'm telling you, to get a patient, I'm sure you've seen this too, to have a patient come back for their other side after they've had a reverse on one side is very easy. They're happy to do it. They're like, look, what are we doing the next side? So it's an easy talk. Today I did his reverse 6 years ago on his other side, and this morning I did his other one. So they're easy to get to come back, and they love the results and they're happy with them.
I 100% agree. I want to trend now towards the sports medicine part of your practice and how you got into that niche. And you touched on it a little bit earlier, but exactly what it is that you do and the athletes that you take care of. My much less experienced sports medicine practice than yours. Mine's on a very minor level, but high school, early college. But they are so much more physically demanding and frequently not very good at the rehab part of it. How do you get them? Well, I think probably your reputation and the work that you put out there. That when they come to you, they probably have some idea of what it is that they're going to get into. But how do you get them to basically become a better rehab patient? You and I both know you can do the same surgery on 10 different people, but how they come out of it depends on how they behave and how they rehab.
Yeah. So that's it. That's the adolescent athlete is first of all, just a challenge alone, just to kind of communicate with them. It was great when my kids were younger because you could talk to the boys about the video games, and they kind of, oh, you kind of know this, and so you kind of speak their language, and then they kind of perk up a little bit if you kind of know what's going on, and you can kind of get into them a little bit. And but I think, yeah, it's a big challenge. I think especially because their perception of time, at that age is so perverse, in the sense of, 9 to 12 months seems like an eternity to them, as far as, coming back for ACL or something like that. And even 6 weeks in a sling for an instability, it's like, what? It's like, it's their whole lifetime, so it is. But I think the one thing that I always kind of repeat with them constantly is, one, I tell the kid with their parents there, listen, you don't get to complain about pain or anything like that if you're not doing your exercises. If you're not doing them, we don't want to hear about it. If you're doing your work, having the physical therapy things on your desk doesn't do the exercises. You actually have to do them. And I ask all my patients when they come back after surgery, hey, what are you doing in therapy? And I don't want to hear like, oh, we're just some exercises. No, you tell me what you're doing. Give me your program. I want to know which exercises you're doing. So if they know it, then I know they're doing it. If they don't, we're having a talk. So that's one of the things. And I always tell them, as far as, hey, everybody wants to do well on their test. Okay, the test is the sport. Getting back to your sport. Now, how do you do well on the test? You study, you do your homework, you put the time in, and that's what your rehabilitation is. So if you put that time in there to do well on the test is your sport, and they kind of go, oh, okay. They kind of get that idea. And I said, hey, nobody likes the homework. Nobody likes the studying. This part's awful. I agree with you. But the only reason we do it is so we can have the fun and do well on the test. So that's kind of what
That's a terrific analogy. I'm going to use that. That's a great
please do.
analogy.
Please do. Yeah.
Because they can relate to that. They understand what that means.
Mm-hmm. Yeah. I mean, it's just, it's always trying to, get it in terms of it's all motivating, and my partner's great at this. Because you get the total joint patients, and they're tough early on. They struggle and things like that. And he's like, yeah, pretty much my first and second post-op visits, I'm just a cheerleader. I'm just cheering them along, telling them to keep going. You're doing great. I know it's hard, but we'll get there. The year visit's always easy because they're super happy. They're doing well, they're pain-free, they're out golfing, they're having fun. But those first couple visits are the cheerleading visits, where you really have to kind of encourage them to keep going, and that, yeah, this is all normal and you'll get there.
So, I really appreciate that. I mean, the purpose of this podcast is it has kind of evolved into, now it's more of a peer-to-peer conversation. And in my opinion, the purpose of this podcast is to get tips and techniques from people who kind of subspecialize in this. And you've given us several today, which I'll use in my practice because, it's pertinent, and it leads to better outcomes. And I like the test analogy. I'm definitely going to use that.
Yeah.
So we've kind of talked about your ACL techniques and your shoulder techniques and your arthroplasty techniques. And again, I know you have a very heavy interest in sports medicine. Is there anything else that you wanted to touch on today?
Whenever you kind of get together and start having just this, casual conversation, talking to people, and outside the conference venue where there's a podium and everything else, it's always a little bit more challenging. Everybody feels uncomfortable. You're afraid to ask a question, to ask that dumb question that nobody wants. But this is just, we're just having a talk, and this is what I'd love to do, is, doing some mentorship. We've got a lot of young orthopedic guys in our area now that are, a year or so out, or within 3 to 5 years out. And we'll sit at the surgery center and just kind of sit in the back room, the dictation area, and talk about cases. I remember when I was sitting, one guy, I saw a case on the board. He was a young guy, probably first year of his practice, and it was an OCD lesion. And I said, hey, what do you think about fixation for that? And he's like, oh, I'm going to get these bio screws. And I'm like, yeah, don't do that. They strip out. They'll get about 4 millimeters shy of the cartilage, and they'll strip out. And I said, use metal. You're going to be much, much happier. I said, learn from my mistakes. I've tried it. I've done it. It's super frustrating. Just use metal screws. They'll sit below the surface. They won't ever cause problems, and you'll get great fixation. So I love the kind of the mentoring that we're able to do this far into practice with this much gray hair. I can do it now.
That's where I wanted to go, because I know that you do a great deal of mentoring, and it's important to you. And you have students, interns, residents, and fellows coming through your practice. Let's jump to the fellows. When they come to you, I assume that they're trying to gather as much information and technique as they can from you. And then my impression is that they don't get trained in all of those techniques that you learn over the years in practice. And so I would assume that they would be like a sponge and just try and absorb as much as they can from you. And I know that's an important part of you with regard to your mentorship.
Oh yeah.
And yeah, do you take them all the way from students to fellows?
No, it just depends on when we get them, like in the teaching process. We get some residents here, we get some fellows here. I always joke about fellowship is just learning how to get out of mistakes. I mean that's the main thing you want to get out of fellowship is I learned how to untie arthroscopic knots pretty well during fellowships. Not only tie them but untie them because he did them wrong. So there's some great parts of fellowship. Ben Ma was one of my fellowship mentors, and still to this day we talk, we chat, and he's fantastic. But he gave me a lot of great just kind of advice coming out of there. It's like, hey, give it 3 to 5 years to build your practice before you really feel comfortable. Don't try to even think about anything too complicated early on. Just do the simple cases, get good at those, become efficient. So I always like to give back, for all the great mentors that I've had over time, and just the things and like I said, mainly is trying to keep people from making the same mistakes you've made over time, whether it's in business practice with partners or hiring people or in all the way to the surgical technique side of things. But I think it's really important that the mentorship I think helps really reduce kind of some of the burnout rate that we unfortunately see nowadays in the medicine. Just having someone to let it's there.
I think that's really important because the mentorship is, again, I know it's important to you, but it's really, really important. And I don't think that a lot of people coming out have that experience or somebody that they can go to and learn from. I compliment you for that. It's a really important part of the process. Because again, a lot of guys come out and they don't really understand. It takes, as you know, several years before you're really comfortable. And what I tell my students and residents that come through my program is, I practice in a relatively rural area, and so many of them are going to do that as well. And my advice to them is, you got to hit home runs when you're in a small community and you're just starting. You got to hit home runs. Just for the first several years, stay with what you know, and as you evolve and as you learn and as you get your experience, then you can expand. But if you come out initially and you're just swinging for the fences and you're putting not the best work out there, you're dead in the water. It's important, and I think the typical mentality that I see is they're all going to go out and be a hero. Well, just do solid work and go from there, and the accolades will come, but it takes some time.
Yeah, I think one of the hard things is people feeling comfortable to mentor in their own community. Like I said, I don't mind it. I mean, these are the guys. When I do some other teaching stuff, we're we get student people from all over the nation, but I'm very happy to mentor people in my community. I mean, I think it's this, like you said, the stronger your community is, the better than everybody else is. You're not dealing with other people's complications. Everybody's doing a great job, and all the patients do well. And teaching somebody how to do what I know how to do just helps our community have better outcomes. So I think some people are afraid to kind of make people around them better, but I think we all get better that way. So I don't have a problem with it.
Well, they're fortunate to have you, and not every orthopedic surgeon of your stature has that attitude and that approach. So they are very, very lucky to have you in that role. Again, we've talked about ACLs and shoulders and arthroplasty and your sports medicine background. Is there anything else that you want to touch on? I mean, this has been fascinating. I've learned a lot. Anything else that you want to touch on?
I mean, we'll have to come back for another. I'd love to talk about AI in medicine and just kind of where that's evolving to. I mean, that's, as you know, that's a whole nother conversation in and of itself, and kind of where it may go and where it's at right now, I think is really interesting. I have some interest in that as well, and I think we don't know what we don't know yet.
So let's do this. Now I'll talk with Fairwinds Medical. Let's get this set up. That would be a terrific podcast to do with you. Because again, I think you're probably on the leading edge of that. And the majority of guys and girls don't really know a lot about it or how it can affect their practice. Not only for them personally with regard to their techniques, but also in patient outcomes. And I mean, that's the whole point of this is patient outcomes. So,
yeah.
Dr. Hunter Greene, I can't thank you enough. This has been terrific. I really enjoy it. I definitely will get that AI podcast scheduled, and we'll go from there.
Yeah, well, I just thank you so much for doing this, hosting this, because I think this is just the best way to kind of communicate, learn with each other is just kind of having a very casual conversation about what we do and how we do it, and it's a pleasure for me to be here.
Well, I appreciate it. Thank you so much. This has been terrific. I do really enjoy it, especially when somebody that's knowledgeable and well-spoken as you are. This is great fun to do, and I look forward to doing it again.
Let's do it. Okay.
Dr. Hunter Greene, thank you so much, and we will talk again soon.
Healthcare Unscripted is powered by Fairwinds Medical, the commercialization team behind some of the most innovative technologies entering operating rooms today. With national reach and clinical expertise, Fairwinds moves new solutions from promising to practice. Visit fairwindsmedical.com to learn more.